My name is Roxanne Chabot from RBC Consultants. Welcome to another IDF webinar. This evening, we're going to discover the science of VTAMA. Our moderator this evening is Dr. Firaj Ujir, who is a clinical assistant professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and president of the Southeast Dermatology Specialist. Our speaker this evening is Dr. Ben Ehst, who's co-owner, chief medical officer, and principal investigator at the Oregon Medical Research Center, clinical associate professor, Department of Dermatology at the Oregon Health and Science University in Portland, Oregon. We'd like to thank our supporter, Oregon, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select settings and the phone call in the audio pane, and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and also will be emailed to you 1 to 2 days later. We'd greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, submit your questions using the question chat pane on the right-hand side of your screen. And now, without further ado, I will pass the floor virtually to Dr. Ujir.
Good evening, everybody. Thank you so much for attending this nice webinar with Dr. Ben Ehst. Today's webinar will be again on VTAMA, and it's powered by Oregon. Dr. Ben Ehst is a wonderful gentleman, a graduate of the University of Minnesota when he came to medical school, where he froze his behind off like I did. But a great researcher, as Roxanne just mentioned, and who was part of the Adoring trials as well. So it'll be really good to hear what he has to say about the data. As you know, IDF is a foundation whose principal mission is to raise awareness and to improve dermatology care all over the world, especially in underserved areas through education. Dr. Leon Kircik was the founder of IDF, and through these educational sessions, many webinars have been seen by many people across the United States and the world, including some of these that you see today, and many more, including today's webinar, which is run by Dr. Ben Ehst. To stay up to date with the IDF Educational Series webinars, you can reach the IDF on Instagram, on LinkedIn, and also on Facebook, as well as visit the website at www.idfeducationalseries.com to register for upcoming events. So without further ado, I will let Dr. Ben Ehst get us started, and I look forward to hearing his meeting today.
All right. Thanks for us, and thank you all for listening, and thank the IDF for actually inviting me to give this presentation. It is exciting because I was an investigator on the Adoring trials, and I get to bring to you the science behind VTAMA and why this is a fairly novel treatment for atopic dermatitis. Okay, here we go. Title slide. So VTAMA, or tapinarof, is a 1% cream. The title here is Exploring First-in-Class Oral Hydrocarbon Receptor Agonist for the Treatment of Atopic Dermatitis in Patients Down to 2 years of age. Bear with me. There's a subtle delay between there. Okay, the disclosure slide. I'm speaking on behalf of and being compensated by Oregon. The content I cover will also as well developed by Oregon. It's all consistent with the FDA-approved label and applicable FDA regulations. And unfortunately, I'll not be able to answer questions that are off of the approved label. Okay, the first part of the talk is just going to go into the background of atopic dermatitis and bring us all up to speed so we're all on the same page when we're talking about atopic derm. As you all know, or perhaps don't, but the incidence and clinical features of atopic dermatitis are well described. It's a chronic inflammatory skin condition and unfortunately affects a lot of patients. So it's estimated over 26 million people in the US deal with atopic dermatitis, and about 9, almost 10 million patients are kids or teens under the age of 18. So a burden of disease across age ranges with many of our patients in the younger category. The signs and symptoms vary. One of the most common, if not the most burdensome complaint among patients is itch. And so that is something we're going to talk about in terms of the outcome measures in the ADORING trials. Atopic dermatitis non-lesional skin is often marked by significant amounts of dryness or xerosis, and that's part of the barrier issue that we see in atopic individuals. If you talk about actual clinical changes we see, those vary depending on the stage of the disease. And if you can break it up, generally into acute, subacute, and chronic changes. So someone who first presents with atopic dermatitis or has an acute flare tends to have more erythema, more edema, to the point of vesiculation or oozing and crusting. The subacute changes are, again, marked with more chronicity. So some of the oozing crusting may shift, more papulation, more erythema. You can take on a duskier hue in older standing lesions. And then you start to get lichenification, and that's the, that accentuation of the skin folds that you see in chronic changes of atopic dermatitis. The features also vary depending on your skin type, as well as the location of disease. So if we talk about different racial and ethnic groups, there's a Fitzpatrick type 2 patient on the left showing you atopic hand eczema, involvement on the hands there. And you can see the marked erythema, that crusting vesiculation. Erythema in general is probably the sign that changes the most across the different skin types. As you see and you advance into the darker type 5, type 6 Fitzpatrick types, you start to lose some of the real kind of beefy red erythema, I call it. It becomes more of a purple or violaceous hue. It can be a little more challenging. So obviously, examining the patient under, good lighting. I often ask the patient as well, can you characterize the amount of redness you're dealing with as well? You can get more papular changes of eczema. We sometimes see that in darker phenotypes as well. So again, being on the lookout for different morphologies is helpful trying to make the diagnosis. The other thing we know is that the eczema not only affects patients in terms of the way they look and feel, but it also has significant comorbid challenges, including mental health issues. So we talked about some of the physical changes: itch, the erythema, the irritation of skin, the dryness, but it leads to scratching, which of course can lead to open wounds and sores, and that's obviously an annoying complaint of patients. If you talk about some of the epidemiologic findings, you can see things that report comorbid psychiatric conditions high in many patients with atopic dermatitis, including things like anxiety and depression. And that can affect kids quite significantly. It can lead to, absence from school. Just sleep disturbance is common. Up to 50, maybe even 80% of patients can deal with problems sleeping, which obviously has snowball effects not only on the affected individual, but you can have problems with caregivers as well. And there's a big impact on these families with kids that have moderate to severe atopic dermatitis. This is survey data showing that on average, peds patients with atopic derm get on average 3 different prescriptions for their atopic derm filled annually. And about a third of caregivers in this survey actually said they spent more than 11 hours caring for their child with atopic dermatitis. So again, it's not just skin deep. It doesn't only affect the skin, but it has significant effects on quality of life and family members who have to deal with these poor patients. So how do we advance our understanding of pathogenesis? This is something, of course, that's changed over the years. And we now know that there are probably 2 different issues. This is the whole chicken before the egg discussion. And that is that in atopic individuals, there's a heightened immune response. So we know there's immune dysregulation that involves activated T helper cells, predominantly in the Th2 type, or the type 2 inflammatory cell category. And those cells make, exuberant and inappropriate levels of inflammatory cytokines such as IL-4 and IL-13. We also know, in addition to the immune dysfunction, there's a barrier issue in these patients. And so the skin barrier itself is not functioning like it should normally. And that leads to breakdown, increased permeability. There are more pathogens, allergens, irritants, insults to the system that can get through an impaired barrier. And that, of course, then generates an immune response, and the dysregulation continues. So there's this dual issue because the skin barrier is not functioning properly on the background of this heightened immune dysregulation. So if you want to advance care for atopic dermatitis, it's a good idea to try and think about addressing both of those pathogenic issues. Many of our therapies we know do a great job at counteracting the immune dysregulation. What I'm going to try and show you is that an oral hydrocarbon receptor agonist, such as tapinarof, can actually affect the barrier as well. So I'll get to that in a second. So VTAMA, this is the first on the ISI, Important Safety Information slide. This is from the package insert directly. It's always good to remember the indication, which is, again, it's approved for peds and adult patients over the age of 2. It's an oral hydrocarbon receptor agonist, 1% cream, topical treatment of atopic dermatitis. Note, it does not give you a category of atopic dermatitis. It's approved across severity levels. Some of the adverse events that are seen more commonly in the clinical trials in patients that were on the VTAMA compared to the vehicle cream are listed here, and we're gonna break those down later in the talk. Okay, oral hydrocarbon receptors. Probably didn't know a lot about these until this product was developed. So the oral hydrocarbon receptor, it's in many cell types of mammalian cells, not just humans. It's expressed in the epithelial, the immune cells, barrier tissue such as the skin, the GI tract, and the lungs. The oral hydrocarbon receptor has agonists and antagonists. What the activation of various receptors can do is promote balanced immune responses by reducing pro-inflammatory cytokines. And it's been shown that tapinarof in general, through its mechanism, can improve barrier protein function. So it actually increases gene expression of genes encoding these barrier proteins like filaggrin and some of the fats and lipids like ceramides. That's a specific function that you see from tapinarof hitting its target. The story behind this is actually pretty interesting. The product itself, tapinarof, was found naturally, so it's a naturally occurring product, and it was discovered in the P. luminescens bacterium inside of nematodes. These nematodes were found to infect a moth larva. And the tapinarof, when it was isolated, was actually found to help function as a preservative after the host was infected by the nematode. So it's a natural metabolite of P. luminescens. And then actually when it was put into human exploration, it was found that it has these very unique properties in our cells. So it's an interesting backstory to how this is this product was developed. And I know I'm going to hit the button too many times as we wait for this here. Let's try one more time. There we go. So this is going to take us into the actual mechanism. So remember, these are all based on in vivo experiments and humans. So these are ex vivo and in vitro experiments. But what we know in preclinical studies is that tapinarof, there's a little movie here. So tapinarof binds to cytoplasmic oral hydrocarbon receptor, and that complex then translocates into the nucleus. It binds with a transcription factor, and the combination then turns on gene production. And that's the downstream effect, these different changes in increasing, anti-inflammatory cytokines, decreasing pro-inflammatory cytokines, and increasing the expression of some of those barrier protein and lipid genes. So again, the big takeaway, if you remember anything from the talk, is the way this thing is unique is VTAMA actually has this dual property. Reduces the inflammatory IL-4, 13 other Th2 cytokines we see in atopic dermatitis, and actually potentially can restore barrier function because it's acting on those pathways. So those are two issues we like to keep in mind when you think about this novel medication. Okay, that's the setup, and we're going to take you into the clinical trials now. So again, this is a first-in-class agent, once daily. It's a one strength, one formulation product. We're going to go over 3 clinical trials. The first two, the Adoring 1 and Adoring 2 trials, these are the pivotal trials that were used to actually get the approval from the FDA for VTAMA. So these are two identical trials. As you see, about 400 patients in each of the two trials. There's a randomization 2-to-1 in each trial to patients receiving tapinarof versus the vehicle cream alone. They're not allowed to use anything else for atopic dermatitis. They are allowed to moisturize, but only on non-lesional skin. The baseline population is shown on the left. You had to be over 2, so 2 years of age or older in the trials. You had to be a moderate to severe atopic. So that's the VIGA, or Investigator Global Assessment Score. That again ranges from 0 is clear skin, 1 is almost clear skin, and then it's mild, moderate, severe, 2, 3, 4. So you have to be a 3 or 4 moderate to severe to get in. The EASY score is a complex score that it's based on the redness and lichenification and the excoriation and the edema you see, and it's weighted over the body areas. You had to have an EASY of 6 or greater to get in. And the body surface involvement could range from as low as 5% of the body. That's 5 of the patient's palm prints or hand prints. So actually, that's still a good amount of eczema. And up to 35%, a third of the body covered in atopic dermatitis, where we could apply the cream. Just a brief touch on the diversity of the population. Look at the bottom there. About 50% of patients in these trials were patients of skin of color. That was self-determined by racial and Fitzpatrick skin typing of the individuals in there. Again, it was down to age 2, but there was a whole range. We had someone up to the age of 81 in the trials. But remember, about 80% of patients in the trials were peds patients. So again, heavily weighted to that pediatric age group. We talked about the efficacy endpoints. You're looking for patients going from moderate to severe atopic dermatitis down to clear or almost clear. So a 2-point movement or greater. There are secondary endpoints in the trials, which includes, EASY scores and itch scores. We'll talk about those. And then we're also looking at safety and patient outcomes. The primary endpoint of the Adoring trials is 8 weeks or 2 months of application. So keep that in mind. All right, you take moderate to severe atopic derm patients, 5 to 35% BSA, and you have them apply VTAMA once daily for 8 weeks. And what you find is in the two trials, large patient populations, again, very replicable results. You see about 46% of patients with clear or almost clear atopic dermatitis after 8 weeks of VTAMA, compared to around 13 or 18% of patients on the vehicle itself. There's a fabulous bar graph that is not, oh, there it comes. There it is. So, I'm going to go back one here. The two trials have very, very similar results there, as you see in the efficacy results. So again, 46% average in the two trials. So again, that's looking at completely clear or almost clear skin over the 8-week time course with low rates of the vehicle. So the vehicle, in a clinical trial, the cream vehicle actually is improving eczema as well. So you do see some responders there, but clear differences. This is looking at the two trials pooled together, and we're going to look at a time course. And the results here show that as early as week 1, you can see patients already getting to clear, almost clear, which continues to rise throughout that 8-week time period. So again, this is the two trials combined. If you start on the right side and look at week 8, there you see that 46% number, the two trials combined. But if you go back and you look as early as week 1, you're starting to see a difference there. So, 6% of patients already clear, almost clear at week 1, rising to around 20% by week 2. The caveat of these is this is a post-hoc analysis, so you cannot make direct statistical comparisons of the efficacy between the groups. But early response rates as early as week 1, looking at those combined data. How about if we look at the different age groups? You may be saying, what about, the really young kids, the 2 to 6-year-olds, or what about the teens, the 12 to 18-year-olds? And the basic gist, I think, is that you don't really see marked differences in response rates in these two different patient populations. So again, the VTAMA group is in the fuchsia, and the bright purple-pink color there, and the gray is the vehicle cream groups. 2 trials back to back, or left and right there, during 1 and 2. So again, over half of patients clear, almost clear in the youngest age group, and around 45 to 50% of the 7 to 11-year-olds and the teenagers. So good response rates in terms of clear, almost clear skin, regardless of which age range. So even the youngest kids. And again, it's nice to pull out these, these pediatric patients, because that huge burden of disease in this population. Secondary endpoint. This is looking at the patient-reported, improvement in their itch. They're asked every day, and there's a weekly average calculated that says, if you recall your itch over the past day, how many on a scale of 0 to 10, where's your itch? And 10 being intractable, unimaginable itch, and 0 is none. If you move 4 points down that scale, that's considered clinically meaningful in a clinical trial. And what you're seeing here is that over half of the patients had meaningful improvement in their itching by 8 weeks. It's a 1.5 to 2 times as many patients reporting that, that patient-reported outcome, that improvement in itching on the VTAMA compared to the vehicle. And again, because itch is such a burdensome factor, this is a great result, because you can tell your patient, hey, I'm anticipating your skin looking better and your itch improving as well. The follow-up, of course, is, well, hey, how quickly is my itch going to go away? Because I'm really unable to sleep, and it's driving me crazy. What can I do about my itch? And as early as week 2, you could actually see differences in the 2 groups. So this, again, is a post-hoc analysis pooling the 2 groups, and this is looking at the mean change in that daily score. So everybody starts at 0 by day 1, and then day 2, you start to see separation, where the group that's using VTAMA is reporting a larger drop on average in their itch. And as you see, it continues to improve over the first 2 weeks and onward, as we saw. I'm going to show you 2 more graphs here on improvement in itching. Again, a little different ways to look at the results here. And this, again, is going back to the proportion of patients reporting meaningful improvement in itch. And we saw that, that final number there at week 8, but as early as week 1, you can see patients, again, are starting to hit 4-point movement on that itch scale. And again, it rises, about 1/3 of patients are meaningful improved in their itching by week 2, more to week 4, all the way out to week 8. Again, post-hoc, so you can't make direct efficacy comparisons, but you can certainly look at the difference in the curves here. And then this is one other measurement, which I think we like to see, because, if you move 4 points on the scale of itch, that's good, but you still may be itchy. So it's nice to go down to minimal to no itch. So this is looking at the percentage of patients hitting 0 or 1 on the PP-NRS. And again, if you look, you're seeing separation by week 1, continuing out by week 4. A quarter of the patients have no itch, or 1, which is essentially, it's not having any meaningful impact on their daily life. So, VTAMA use once daily, 8 weeks, 1/3 of patients have no impact on their daily life from their itching. So that's good. You're getting efficacy. You're getting improvement in itching. The other question is, well, the clear, almost clear patients, that's a binary endpoint. It's saying, hey, how many patients reached this hard endpoint of clear, almost clear? But what about the patients that were severe and then may have gone to mild? They may be very happy with VTAMA, but they're not counted on that other group. So the other way to look at this is looking at the EASI improvement scores. So again, EASI 75 just means whatever your score you started at it's gone down by 75%. So how many patients are 75% better in that score at the time points? And here again, you're almost around 60%, 55 to 60% of patients using VTAMA for 8 weeks are at least 75% better. And again, that's a 2 to 3-fold difference compared to the vehicle cream group. So again, that gives me a broader picture of what the entire group that's using the cream does, compared to just saying how many get to clear, almost clear. You can look at one more way. This is looking at 50%, 75%, and 90% improvement rates in that EASY score. Because again, even 50% improvement, is a significant change there. And then again, by 8 weeks, VTAMA once daily, 3/4 of patients at least 50% better in terms of their EASY score. And of course, the bar gets higher, so the curves fall a bit as you go to the 75, which we saw. But if you move out to the EASY 90, you actually see that a large percentage of these patients that are, 50 or 75% better are actually at least 90% improved. So you're, again, up about at a third of patients using VTAMA once daily for 8 weeks are 90% or better in terms of their skin score. And then again, that placebo response rate drops because that's a hard bar to get to with just the cream. So a little bit different way to look at the results, but that gives you maybe a better idea of what the population is doing using VTAMA. Okay, what about the subgroups of EASY 75 responders based on ages, just to make sure we're also seeing good responses in the different pediatric and teenage groups. And again, my takeaway is you see higher percentages than you saw with the clear, almost clear score. And again, good differences across these. Hard to make much of a comparison between groups. And that's actually not something you can do based on the way the study was powered. But again, you're at the, over half to up to, 70% or so of patients, at least 75% better by the time they hit 8 weeks. And what about skin tones and different treatment areas? So I'm going to show you a series of photos now, and these are actual clinical trial patients. This is a 9-year-old girl, Fitzpatrick type 4, and that's the antecubital fossa on her arm. And this is the baseline. So before she started the trial applying VTAMA, there's a 7-year-old Fitzpatrick 6 looking at a tough to treat area on the foot, around the ankle there. And then we're going to jump to an older individual, 54-year-old male with a tough to treat area on the palmar aspect of the hand, Fitzpatrick type 2. So a range of disease areas as well as skin types here, including some of the traditionally harder to treat areas. So let's now look at the 9-year-old and that antecubital fossa. Now I know I'm going to start hitting the button too quickly. So there's the baseline photo again, and I'm going to go right to the next photo. That's 2 weeks on VTAMA. And just looking clinically, you can see a significant improvement there. If you look at the actual scores, globally, the investigator said the patient started as a moderate and was already down to mild disease. Of course, that includes other areas of the body potentially. The EASY score had dropped significantly from 26 down to 8.8. The child DLQI, so that's that's the caregiver answering quality of life questions. That has dropped from a 5 to a 2, 0 being great. Actually, 0 or 1 on the DLQI is considered no impact on quality of life. So almost there after 2 weeks. And the itch has improved as well. Here's week 4. And by week 4, this individual has become a responder. Her IGA now has dropped to a 1 or almost clear overall. Again, the DLQI is at 0 now. That itch score has improved again down to a 3.6. And by week 8, she's still almost clear, so she must have a little bit of erythema or lichenification or edema somewhere, but essentially minimal activity and minimal quality of life issues. There's a great success. How about the boy with the ankle involvement? Okay, a little younger. This is a 7-year-old guy, and he is a Fitzpatrick type 6 dark skin. By week 2, is still moderate overall, but clinically, I can already see improvement there. And if you look again at the DLQI, it's dropped down to a 2. The itch is also improved from a 7 down to 2.3 again on that 10-point scale. By week 4, and on to week 8. By week 4, overall considered mild, fairly consistent at that stage, but some improvement as well. But by week 8, this individual is now a responder, considered almost clear atopic dermatitis, a 1 on that scale, with no real impact in terms of itching or quality of life measures, including the POEM score. So there's another treatment responder, again, a hard to treat area. It took a little longer. And that may again reflect some of the the application site where the skin is thicker to begin with, but a great result. And then we're going to use the older individual here as an example, someone who actually was considered a non-responder. So he actually did not meet the IGA criteria, but I'm going to show you his hand. So overall, this patient was considered severe at baseline, and I think even that hand looks pretty severe. Easy score of 11. That's close to what will qualify this patient for a systemic therapy trial, actually. By week 2, the disease has gone from severe overall down to a mild phenotype. So already, drastic improvement there. Itching hasn't changed much, which is always interesting when there can be a disconnect between the clinical findings and the itch score. But the DLQI is improving as well. That hand looks more remarkable. So again, the hand itself may be almost clear, and it does look really good. And there's some activity elsewhere. So again, this patient is still considered mild overall. Again, probably other parts of the body involved, and was still mild at week 8. But yet, this hard to treat area like the palm or aspect of the hand, it looks wonderful. Has a great response there too. So I think examples of patients that actually count as responders, and then a good example here where someone actually was considered non-responsive in the trial, but obviously, at least in this body area, had a good response to the 8 weeks of VTAMA. All right, that's the efficacy. Let's do safety next before we get into the Adoring 3 trial and then bring it home there. So this is that list I showed you on the important safety information slide. So this is the breakdown of those things. So these are all the things that happened in more than 1% of patients who were on VTAMA compared to the vehicle cream group. And that's it. So it's about 1, 2, 3, 4, 5, 6, 7, 8, 9 different things. So these are 9 things. I run down the list. The first thing I say is all those things look okay and not too worrisome to me. I then look over at the VTAMA group versus the vehicle group in white, and I'm looking at the percentages. And what I see is that URIs, that's the number 1 adverse event that was reported, happened in 12% of patients on the VTAMA compared to 6% on the vehicle. The next one was folliculitis, 9% versus 1%. So there's an imbalance there for me. You saw differences in you got lower respiratory infection, headache 4 versus 1%, and then very low percentage of asthma, vomiting, ear infection, pain in extremity, abdominal pain. So these are differences that do happen. Some of these I think can be explained by some of these are lumping categories. So URI in particular here includes things like sinusitis, rhinorrhea, viral upper respiratory infection, streptococcal infection. So it's a lumped category there. But these are common issues that again, in my opinion, are not worrisome as an adverse event from a product like this. Another way you can look at this is how many patients actually said, I had an adverse event and that's enough for me to call it quits. And what you found is that there were low rates of discontinuation. And in fact, the patient groups using VTAMA who had an adverse event were less likely to quit the trial than those using the vehicle. As you see there, about 1.9, 1.5% of dropout discontinuation because of an adverse event on VTAMA versus about doubled on the patients using the vehicle as well. So again, they do occur, but to me, it's a reassuring finding that even if some of those events were occurring, the patients themselves were saying, I'm okay with continuing on the trial. I'm going to finalize this with the Adoring 3 trial. So Adoring 3 was an open label long-term extension. This was essentially a year-long. It's a 48-week trial, and open label means everybody they know they're getting VTAMA. What's unique about this trial is it was trying to mimic what may happen more when we're prescribing this to patients, and that is if at any time point, including entry to Adoring 3, your skin was clear, then the investigator was told to instruct the patient not to apply VTAMA. So you got to stop using it, and then you would wait. And if or when your eczema came back anywhere in the body and it was considered mild again, you'd reapply VTAMA. And then you do it again. If you cleared again, you'd stop, you'd wait. If it became mild, you go back on. So patients in this portion could have gone on and off. They may have entered the trial clear and stayed clear the whole time. They may have never achieved clearance and kept using VTAMA throughout. So you get an idea of, hey, can you continue to use this safely throughout 48 weeks plus the initial 8 weeks? Can you come off and on? What happens when you do that? So it's a very robust trial design. As you see, there are 4 different groups. The 2 trial Adoring 1 and Adoring 2 patients, they could all opt to go on to the long-term extension, which the majority did. There were 2 other trials that rolled into this. One was a maximum use trial where patients were applying VTAMA to large areas of the body. And then you could directly enroll. The direct enrollment group, about half of those 76 or so patients, about half of them were actually mild atopics. So they were not allowed in the first 2, but they were allowed in this. So there's some mild patients in here. And then the other half were patients that were moderate to severe, but may not have had enough body surface area, say, or too much. And they were allowed in here as well. Excuse me. And this trial again looked at, how do the patients do in terms of efficacy on and off VTAMA and safety events as well. Okay, so again, looking at those things, time off treatment was the big question. Throughout this, again, you could not use other topical or systemic treatments for your atopic derm, and you could use emollients, but only on the non-lesional skin. And I explained how you came on and off VTAMA, and the fact that you could be mild as well. So there were mild patients in here. That, of course, is why the FDA was comfortable saying it's approved for all disease severities. All right, 720 patients in those 4 different trials enrolling into Adoring 3. And what they found was that what was called disease control. So 82% of patients who either entered with clear skin, so in the first 8 weeks they had achieved clearance, or had not but were using VTAMA throughout there. 82% of patients at some point in Adoring 3 were clear or almost clear. So at least once, 80%, 8 out of 10 patients using VTAMA will get to clear, almost clear, at least once over the course of that 48 weeks. And again, some could have gotten there more than once. Some could have gotten there and stayed there as well. But that's a better kind of indicator of long-term, disease control. Does it work? It works in, 82% of patients. Complete disease clearance is the higher bar as well. So 52% of patients, again, in this large cohort, actually maintained or got to clear skin. So again, 1 out of 2 patients using VTAMA in this 48-week period, at least some point, were completely clear. That's the group, again, that would have come off VTAMA. And then the other exciting thing is, if you did reach clear and you stopped, on average, it was 2.5 consecutive months where you didn't need to apply anything before your eczema came back to mild. And again, that's exciting. Of course, there could have been some patients where it came back sooner, and I know there are also patients where it was months past that before they had mild disease. So it's a nice number to talk to patients about as well, saying, hey, in the clinical trial setting, actually, patients who actually became clear, on average, they could take a break for 2.5 months and not have to apply anything. And that's a huge thing if you think about that, that burden of, caregivers, for instance, dealing with kids and having to, rub agents on their skin continuously. So this is it's a nice discussion point. And a pretty cool and pretty interesting result we see in the trials with VTAMA. What about adverse events? So it's always nice to get an idea of, hey, if you actually continue to use this over time, are you going to see different things? So the adverse events of special interest, I pointed out 2 of these. Contact dermatitis was very uncommon. About 1.5% of patients overall had what was categorized as contact dermatitis throughout this long-term trial. Contact dermatitis was not something that required patch testing. It was a clinical diagnosis made by an investigator in the trial. So that's a low rate. The follicular events, it was about 14% of patients overall. So again, follicular events do happen with VTAMA use. It's still an overall low percentage. The vast majorities are application site events. So it's usually, I think it's above 90% of patients had these where they're applying VTAMA. And they're mild to moderate severity. They didn't lead to patients actually stopping. And then headache occurred as well. We saw about 4%. It's down to 3.7 in a longer-term trial. Again, these were not events that led patients to discontinue the cream. If you go back to most frequent adverse events that you see over the course of that 48 weeks, it was the similar findings. The folliculitis was actually number 1. Then it was nasopharyngitis and URI. Here in the extension during 3 trial, those 2 terms are actually broken out separately. And again, overall treatment emergent adverse events leading to discontinuation was low. 2.6% of patients over those 48 weeks said, hey, this side effect I'm having is enough and I'm going to be done. And as you see there, these events of special interest, the contact derm, follicular events, headache, mostly mild or moderate, and very low, 1% or less, led to actually patients discontinuing. Nobody with a headache actually discontinued VTAMA. And so that's basically showing that over this period, there's no new safety signals that was identified, including in the pediatric group. So that's a great safety point there. All right, we're coming to the end here. So VTAMA, first in class oral hydrocarbon receptor agonist. It is the first and only, again, approved for the treatment of atopic derm in patients 2 years of age and older. Hopefully, again, you've taken away that the agonist effect of this medication and on its receptor is both anti-inflammatory and hopefully restores skin barrier, again, based on these ex vivo in vitro mouse models. The specific way it does this in humans is, of course, not directly known. We've now shown proven results across disease severities, across different skin tones, and across treatment areas, including some traditionally hard to treat areas. I showed that last Adoring 3 data showing on average 2.5 consecutive months or 80 days when you're cleared your skin and stop treatment before you go back to having any mild activity. And a reminder again, we didn't mention this yet, but again, it's a steroid-free formulation. And it has no to minimal systemic absorption. That was determined in that maximal use study. So remember again, the power of 1, once daily, 1 strength, 1 formulation. You remember 1% as well. So you can apply VTAMA to all areas of the skin, although it's not approved for use on the mucosa or obviously the ophthalmic or intravaginal areas. Across disease severity, so the indication is patients with atopic dermatitis 2 and above. No labeled warnings or precautions. There's no limitation actually on the BSA in the label. There's no limitation on the label to duration of use, no contraindications, no drug-drug interactions. And based on that maximal use study, again, no to minimal systemic absorption. So that's the summary. Now you say, how do you get your patients onto VTAMA? And of course, this process will hopefully be familiar to many of us. This is based on patient feedback actually showing that it's cosmetically elegant. Again, once daily, it's non-greasy. You're seeing the actual tube, a little smaller than the actual size tube, but that's the tube. It doesn't have any fragrance, petrolatum, parabens, PABA, hexylene glycol, or gluten, which is a good thing in Oregon. We're getting there. Here you go. So the instructions are to apply a thin layer once daily, only to the affected areas, obviously. Wash your hands after you've done that, unless you're using it to treat. And if someone like a caregiver is putting it on, then they're supposed to wash their hands after use as well. So when you're writing it, the reminders here again is, in your office notes, make sure you use the correct, ICD-10 codes for atopic dermatitis. We didn't mention, but VTAMA is also approved in the plaque psoriasis population. Use those codes if you're treating psoriasis. It's good to include prior therapies, including topical corticosteroids or TCIs if they've been used. Note if you're potentially using this on special sites or sensitive areas where a TCS would be contraindicated potentially. You send it in, you can see if they're, the health plan may have to use a specialty pharmacy and network. You can go through various specialty pharmacies that have experience using VTAMA. Some can directly ship to your patients, obviously. If you are commercially insured and eligible, patients can pay as little as $0 per tube, and that's through the VTAMA savings card, which is accepted at many tens of thousands, actually, U.S. pharmacies. So there you go. That's my talk on VTAMA. Hope you enjoyed it. Hope you took something away. Please scan that QR code if you want to learn more. Get the direct package insert. And a reminder to fill out the survey when you're done. And thanks for listening. Faraz, you're muted. I don't read lips well.
You missed out. The meaning of life was just given to you, and you missed it out.
Bummer.
I apologize for that. I was thanking you, Dr. Ehst, for a wonderful and thorough presentation. This was really interesting and instructional. A few questions came through. I'd like to ask you one of them. That's okay.
Yeah.
We get this a lot. Who is your, and this for any product or any treatment, but who is your VTAMA patient? Who do you consider for VTAMA treatment?
It's a great question. And it's a hard one to answer. I don't necessarily have a patient that I wouldn't prescribe it for. So it can really be used for anybody. Again, my algorithm still contains corticosteroid up front. Usually that's because of access or the need to do that. It's kind of the gold standard. But again, someone who's already tried corticosteroid or is needing to continue to use it, or again, if it's these younger age groups where you don't want to use a strong corticosteroid. There's concern about actually using that. This is a great product because it's not steroidal. It's not going to cause some of those known side effects of steroid. It's tolerated well. You can apply it everywhere. You don't want to be applying something greasy and something that may irritate to to your 3-year-old in the folds of the groin, say, right? So I don't have a patient I wouldn't prescribe it to. I definitely have used it in patients that have experienced other, medications over the years and are frustrated or ready for something else. It's a great thing. You have another option now to say, hey, gosh, I've been giving you the same thing over the years, and I have a totally new option. And it's unlike anything that's out there by, the way the mechanism, the way it works. I actually found it, pretty fun to talk about the story of the nematode and the fact this is a natural ligand, and we're going to go for it.
Well, you are in Oregon after all.
That's right.
Donna also asked this question about, have you used it in fissuring, thumb fissuring and hand eczema?
I haven't directly said, hey, put it on your fissures, but I've had plenty of patients who are fissured, and I have not, to my knowledge, had people complain of burning irritation as well. So again, I think hands can be a harder area to treat. I have no qualms of saying, hey, it was used there in the trials. Go for it and let me know how you're doing.
Wonderful.
Yeah.
And another question going back to steroids, how important is it for you to use steroid-sparing agents or to avoid the use or to at least have other options than steroid creams?
Again, I think it's huge. Steroids do tend to work, but they're a short-term fix. And it's the chronicity of these things like atopic dermatitis that you're stuck over time using these steroids. And that's something we got to avoid. So again, here's a 48-week period where some patients used it continuously, and you're not worrying about side effects like atrophy. And I think we've all seen those patients who have their skin is awful because it's so thin from years of corticosteroid. So I think again, it's very important. I think moving past the steroid it should be a goal of everybody, unless you're treating something that's short-term acute. then it makes sense.
It is helpful to have something we can give patients and not have to worry about how many refills they use or what happened and any side effects come with that. Okay, and true. I think that the last question I have so far, unless more come up, talk to us a little bit more about skin barrier repair and how that would fit in your treatments of atopic dermatitis or psoriasis, and how VTAMA works with that.
Yeah, I mean, I think the skin barrier is such a huge component, and we've known about that forever, and we've always said that's why I use emollients, and and moisturizers help. There was a period where there were some of these specialty creams, mixed in with specific ceramides and things, and they didn't really pan out. So I think we've been lacking something that directly says, we know atopics have an intrinsic issue with the barrier usually, and how can we address it directly as opposed to perhaps indirectly, where you're going after inflammation and letting the skin hopefully correct. So to me, this is it's a unique property. I don't want to speculate too much on how great this may be, but it's something to keep in mind, I think, when you're picking products, to say, we know there's a specific barrier defect, and VTAMA may actually improve that. So, hey, let's try something else. So again, I think it's an important thing. I think it's been known for a while. I think actually being able to change or improve the barrier directly is something that hasn't always been easy to do. And now we have a product where, at least in experimental situations, you can see that it's upregulating cornified layer proteins and things, and that's cool.
Wonderful. Well, Dr. Ehst, thank you so much. I think we're coming to the end of our discussion. Thank you also to the IDF supporter, to our supporter, Organon, which made this possible tonight. It was wonderful to talk to you about this. Our next meeting, you will get to hear from Dr. Brad Glick, a great friend and a wonderful speaker, who will talk about fast relief from hives and itch with Rapsido, our new approved drug for CSU. Please plan on being there on Thursday, the 18th of June, 2026, not 25, at 7 p.m. It should be very interesting talk. Again, thank you for joining us, and thank you for being here today.
Thanks, everybody. Good night.
Good night.
Thanks. Good night.